Welcome to this brief tutorial on lung compliance and pulmonary compliance. Compliance itself is distensibility of a tissue. Elastance, on the other hand, is the ability for a lung to return to the volume it was at previously. So compliance is the stretch and elastance is the recoil. Lung compliance is simply a change in volume divided by a change in pressure. In this case, it's the transpulmonary pressure dealing with the lung. Compliance is the reciprocal of elastance. So therefore, if compliance is the change in volume divided by a change in pressure, elastance is a change in pressure divided by a change in volume. So if you know one, you can calculate the other. Increased compliance, similarly, equals decreased elastance. Compliance is best at functional residual capacity. Compliance is better with dry lungs than wet lungs. So normal compliance is optimum compliance. Compliance may decrease, or the ability to distend the lung decreases, as we move away from our functional residual capacity. So if our lung is very collapsed, we have poor compliance. And if our lung is very over-distended, we have poor compliance. If our lungs are wet, they are poorly compliant. If our lungs are fibrosed, they are poorly compliant. Clinical examples we may use to describe poor compliance: over-distension, breast stacking on a ventilator, not allowing the patient to breathe out before the next breath is delivered. Similarly, a very similar process occurs in asthma. Patient can't breathe out, so the volumes increase. Cardiogenic pulmonary edema, the lungs are wet. Non-cardiogenic pulmonary edema, which we might describe as ARDS. Any fibrosing disease, any disease that decreases the thoracic cage volume, such as severe kyphoscoliosis or morbid obesity, will also lead to poor compliance. We need to know a value for normal compliance, and the normal value at FRC for the lung, not the total compliance, but for the lung, is 200 mils per centimetre of water. I think you should know this value, and I think you should know these units. And as it's at FRC, it is the best compliance for that patient. Lung compliance at FRC. If I couldn't remember the normal volume, and I couldn't remember the normal units, if I could work them out in my Viva, I think I would score quite good marks. I think we all should know that a normal tidal volume is about 500 mils, and that a normal transpulmonary pressure gradient is small, in this case 2.5 centimetres of water. 500 divided by 2.5 equals 200. Mils divided by centimetres of water equals mils per centimetre of water. And this way, even if we didn't rote learn it, we could remember the number and the units, and this would be better in an exam setting than simply rote learning these values. Respiratory compliance, the compliance of our whole respiratory system, is dependent on the compliance of the lung, which we've discussed, and the thoracic cage compliance, or the TCC. Remember that if we add elastances together, they can simply be added, but if we add compliances together, we have to add them as reciprocals, which is something you should remember when dealing with compliances for your exam. Static compliance and dynamic compliance. These definitions are required in the syllabus. Static compliance is the pressure and volume measured at a steady state. That is, the patient inhales a certain volume and then holds their breath at that volume, and the pressure is measured. Likewise, in the setting of a respiratory therapist, maybe an American intensive care unit, a paralysed mechanically ventilated patient could have different volumes injected, held steady, and then the pressure in the respiratory system measured. And this is something that would be done in some places. Dynamic compliance, on the other hand, is what we see when we look at pressure volume tools on our machine. They're continuous pressure and flow measurements, normal breathing. Because they're affected by resistance, the values for this form of compliance are always lower. Resistance. Resistance occurs to flow, so you need flow to measure it. A static curve eliminates resistance. A similar concept may be found with our pulmonary artery fluorescein catheter, where we block flow with our balloon and measure the pressure distal to the balloon, assuming that there is a column of air, that is a column of blood that is running from the tip to the left atrium of the patient, and that way we can estimate left atrial pressure, taking out resistance. Transpulmonary pressure. I think this area is quite confusing and requires a little bit of thought on our part. In normal breathing, our transpleural pressure is simply the atmospheric pressure minus the intrapleural pressure. In a paralysed patient, the intrapleural pressure is 0 and the positive pressure is what we push into the patient and is measured on our ventilator. But if we use non-invasive or SPONT modes or assist modes of ventilation, or anything where the patient is breathing in triggers, if we want to know the transpleural pressure, we need to know the pressure on our ventilator, but we also need to know the intrapleural pressure. And if we don't know the intrapleural pressure, we are underestimating the transpulmonary pressure. For example, if I'm putting in 15 centimeters of pressure support, the transpulmonary appliance is not 15 centimeters. It has to consider the intrapleural pressure. And if the patient is trying very hard, using a lot of effort, this could be minus 10 centimeters of intrapleural pressure, which makes the gradient 25 centimeters. You need to think about this several times, or in an exam or real world setting, you'll find that you go 15 minus 10 equals 5, which is incorrect. It's plus 15, the difference between that, and negative 10, which is 25 centimeters. So a lot more than it first seems when you put a patient on SPONT. Things always look like you've done miraculous work when you go to SPONT because you're simply ignoring the intrapleural pressure, which can be highly significant. Intrapleural pressure can be estimated with an esophageal balloon, and there certainly are places that would use esophageal balloons, and they would feed those numbers right back into their ventilator, and it would all be considered. This is not something that I have done, but it is definitely done by many doctors in intensive care. Normal breath compliance. Here we have a graph where we have inspiration and expiration. This is our dynamic compliance. Between, we have this gradient as if there was no flow occurring when it was measured, which would give us a static compliance. When we inspire, it takes more change in pressure to get the volume than when we expire, and partly this is because of airway resistance, and partly it's because of the elastic recall properties of the lung, that when we expire, we don't really need a lot of pressure. In asthma, our lung volumes are increased and our airway resistance is increased. This increases the hysteresis, or the difference between inspiration and expiration, and decreases the compliance as well, which greatly increases the work of breathing and can be very distressing in severe asthma. Other things we should consider with this topic: airway resistance, surfactant, surface tension, neonatal respiratory distress syndrome, saline lung ventilation, the effects of obesity. What would happen with atelectasis? How could we optimize PEEP values? How could we optimize our peak airway pressures using pressure volume tools? And in order to do this, I have a reference here to a website, Hamilton Medical, which is a commercial website, but their ventilator, which I'm quite familiar with, has a protective ventilation tool that goes into each patient, puts in different volumes, works out the compliance, works out the resistance, and the machine itself then titrates what it believes to be the optimum measure, the optimum mechanical ventilation. Not only this, but it also measures, these ventilators measure when the patient's ready to spontaneously breathe and when they're ready to extubate. Quite literally taking these skills away from the bedside clinicians potentially. But I guess this is where this field is going.